Just reminder, Google Hangouts has muted you. So if you do need to speak to the group, please press *6 on the phone to unmute and mute. There'll be certain times where you'll be able to talk stuff. You'll know. Second is if you are using your laptop for audio and visual during the meeting, you could control the mute function on the Hangout, which is located at the bottom. Good morning, Dr. Hoffman. Welcome. So just a reminder that if we kindly ask everyone who are speaking to the group to unmute their devices. We don't have the control function to mute someone and unmute them. So also, DURB board members, when to reserve your questions. And then we do have a speaker today from Immune, so that'll be Dr. Payne. So whenever we do get to that agenda item, we'll discuss that. She'll present as well. So for public comment, if you like to provide public comment, just a reminder, a conflict of interest must be on file with us. And also to make sure we have everyone's information that attended this meeting, if you could please send us an email. If you're via telephone, you could contact us at medicaidpharmacy@utah.gov just to give us a quick email saying, hey, I did attend today's meeting with your name and also your company. And then if you are available through Google Hangout chat, you could also send that information through that chat function as well. So once again, your name and then also your company. So we're able to mark down everyone for attendance. So with that said, we do have quorum and we're all good to go. So Dr. Smith, we can go on to the next agenda item. No problem, thank you.
Great, thank you. All right, so review and approval of minutes, I believe is where we are. I had a correction and I just stuck it in the chat box because it was a couple of things.
Perfect.
Just in a nutshell, under 5C, referring to our discussion about the prior authorization criteria under atopic dermatitis, we needed to make sure it was clear we were talking about the systemic immunomodulator step-through therapy.
Perfect. Thank you so much.
Yep. Anybody else have any corrections on the minutes? Is there a motion to approve them?
I move we accept the minutes as stated.
Thank you, Neil. Is there a second?
I second the motion.
Thanks, Dr. Siegfried. All in favor of approving the minutes?
Aye.
Aye.
Aye. All right, thank you. Those have been approved. Okay, next item on the agenda is P&T committee update from Brian Larson.
Yeah, next week we'll have our P&T committee meeting for September, and we'll be discussing biologic treatments for asthma. So this is the benralizumab, tupilumab, mepolizumab, omalizumab, rezalizumab. I think that covers them. So we look forward to reviewing those and hopefully getting those on the PDL at some point.
Sounds good. Any questions for Brian? Great, thank you. All right, I guess we're jumping right into it. Our next item is the Palforzia prior authorization.
Sorry. Yes, we'll go through the presentation and Noon has that,
Perfect.
so she'll be presenting.
Thanks.
Perfect. Thank you.
Good morning. I am going to present the Palforzia, or it's another name of it, the peanut allergen powder. Please let me know if you see the PowerPoint.
Yes, we can see it.
Thank you. So the prevalence of peanut allergies and food allergies in the United States, approximately 32 million people in the United States have food allergy. This is from the data of 2018 and 2019. Out of 32 million, 6.1 million have peanut allergy. Roughly 5% of the newborn have peanut allergies at data in 2017. The prevalence of childhood peanuts or trinas appeared to have more than tripled between 1997 and 2008. Peanuts is one of the most common food allergy besides milk, egg, trinas, wheat, soy, fish, and shellfish. Teenagers and young adults with food allergies are at the highest risk of fatal food-induced anaphylaxis. Allergy reaction can result from mislabeling or cross-contact during food preparation. Majority of fatal food allergies reactions are triggered by food consumed outside of home. Statistics show that more than 15% of school-age children with food allergy have had the reaction while at school. On-throw allergies to milk, eggs, wheat, and soy often resolve in childhood. Research does suggest that children may outgrow at least one of these food sensitivity more slowly, with many children still have allergies at the age of 5. But allergies to peanuts, tree nuts, and shellfish are generally lifelong. Palforzia for FDA labeling is an oral immunotherapy indicated for the mitigation of allergic reaction, including anaphylaxis, that may occur with accidental exposure to peanut in patients with confirmed diagnosis of peanut allergy. Palforzia to be used in conjunction with the peanut avoidant diet. The initial dose escalation is approved for patients between 4 to 17 years of age, while the updosing and maintenance is approved to 4 years of age and older. Patients who have started initial dose escalation between 4 to 17 years of age, but can continue the updosing past the 17, can go up to 18 and lifelong. The limitation of Palforzia is not indicated for the emergency treatment of allergic reaction, including anaphylaxis. It is manufactured from the fatted peanut flour. It consists dosing of 3 sequential phases: initial dose escalation, updosing, and maintenance dosing. And this is the initial dose escalation. It consists of 5 levels of dosing: A, B, C, D, E, titration from 0.5 milligram up to 6 milligram. It comes in a blister of 5, a total of 13 capsules. These 13 capsules are supposed to be given in all one single day at the provider office. It is recommended to be each dose to be separate by an observation period of 20 to 30 minutes. And no dose level should be omitted. Recommended to observe the patient after the last dose for at least 60 minutes until suitable for discharge. Recommended to discontinue Palforzia if the patient happen to have symptoms of reaction, usually involve epinephrine. It's a reminder that the initial dose escalation is only approved to 4 to 17 years old. For the updosing, if the patient received the initial dose escalation in one day, it's better if they can receive the updosing the day after at the provider office. If the patient cannot come back to the provider office within 4 days, the patient should be restarted with the initial dose escalation before go to the updosing. The first dose of each new updosing level is given under the provider's supervision in the healthcare setting. The updosing consists of 11 dose level, titration from 3 milligram up to 300 milligram. And each of the dose level will be maintained for 2 weeks before going up to the next level. Recommended to observe the patient for at least 60 minutes until suitable for discharge at every dose level. If the patient tolerates the first dose of the increasing dose level, may continue that dose level at home for 2 weeks. No dose level should be omitted. If unable to tolerate a specific dose, patient can stay on the previous dose for a while longer than 2 weeks. No more than 1 dose should be consumed per day. If the patient have already received the first dose in the provider office, they should not taking another dose at home on that day. Do not progress more rapidly than recommended on this table. At the 300 milligram is the maintenance dose that will continue, I assume, lifelong. There's missed dose instruction. If the patient missed 1 to 2 consecutive days of the Palforzia, patient can resume at the same dose level. If it happened to miss more than 3 or more consecutive days, resumption of Palforzia should be done under medical supervision. Palforzia is contraindicated in patient who has uncontrolled asthma or patient who has a history of eosinophilic esophagitis and other eosinophilous gastrointestinal disease. Recommended to discontinue Palforzia if patient unable to tolerate doses up to and including the 3 mg dose during initial dose escalation, or if patients have suspected eosinophilic esophagitis, or if the patient happened to be unable to comply with the daily dosing requirement, or patient who has recurrent asthma exacerbation or persistent loss of asthma control. For the side effect, during the clinical study, the adverse side effect usually happen within the 4 minutes of taking Palforzia, and it lasts about 37 minutes later. They have some side effect of stomach pain, vomiting, itching or burning in the mouth, throat irritation, cough, throat tightness, wheezing, shortness of breath, itchy skin, hive, or itchy ears. Palforzia commit a warning of anaphylaxis. It is recommended to withhold Palforzia if the patient is showing symptom of anaphylaxis. Commit the warning of asthma, eosinophilic gastrointestinal disease, or gastrointestinal adverse reaction. The safety and effectiveness of Palforzia has not been established in patients younger than 4 years of age. This one is posted on the Palforzia website. On the left side is what the patient should do when taking Palforzia at home. It is continue to have the patient carry the injectable epinephrine. Have the patient taking their dose of Palforzia with the meal at the same time every day. It can be mixed with spoonful of soft food such as applesauce, yogurt, or pudding. That either cold or at room temperature. Keep an eye on the children for the 1 hour after they take the dose in case there's any sign of an allergic reaction. Keep Palforzia in the refrigerator. If the child missed taking the Palforzia, contact the provider. Do not take the additional dose on the same day or make up any missed dose. Be aware of certain conditions that may increase the likelihood of an allergic reaction, including having an illness such as the viral infection, being very tired or missing sleep, being stressed, having a menstrual period, exercising, taking certain pain medication, just as aspirin or ibuprofen, or drinking alcohol. On the right side, it is what not to do when taking Palforzia at home. Do not have the children eat peanuts or peanut product as part of their diet. Do not have the child take the daily dose of Palforzia on the day of the appointment, since they will be receiving some from their allergic. Do not take more than 1 dose of Palforzia on a single day. Do not take any more doses if your child has missed a dose of Palforzia. Instead, contact the provider for the next step in continuing treatment. Do not let the child swallow the capsule or inhale the powder. Do not let the child do not give the Palforzia if they're very hot or having participated in any strenuous physical activity like a game or sport, or still have a high heart rate. Do not let the child participate in sport or other strenuous physical activity or take a hot bath or shower within 3 hours after taking the Palforzia. Palforzia have the REM program, in that requiring the healthcare setting, prescriber, pharmacy, and patient to all be enrolled in the REM program. The requirement for the healthcare setting is to have a certified healthcare providers on site to counsel the patient, monitor and manage anaphylaxis if that happens. Train on relevant staff involved in dispensing and administering Palforzia, verifying the initial dose escalation before the treatment. Assess the patient for anaphylaxis during and after administering the initial dose escalation and the first dose of each updosing for at least 60 minutes. Prescriber is required to counsel the patient on the need to have injectable epinephrine available for immediate use at all times. Required to counsel patient on the need for monitoring the initial dose escalation and first updose of each updosing level, the need for continuing peanut avoidance in the diet, or how to recognize the sign and symptom of anaphylaxis. Pharmacy is required to ensure that prescriber and patient are appropriately involved. Make sure that initial dose escalation is only dispensed to certified healthcare setting and not to the patient directly. Every updosing, only one dose level is dispensed to the patient at the time. So when the patient is show up at the provider office for the updosing, the provider, after the patient show that they're able to tolerate the dose, prescriber will enter the REM program that will trigger the pharmacy to ship the rest of the 2-week dose to the patient home. The patient requirement to must have the injectable epinephrine available at all times to avoid peanut or peanut-containing food in the diet, to know the sign and symptom of severe allergy reaction. When looking at the other state criteria, I could not find any of the SSDC state have reviewing the Palforzia. This is coming from the state that outside of the SSDC. The criteria from the other state is the patient have initial dose escalation start between the age of 4 to 17 years of document clinical history of allergy of peanut or peanut-containing food. Confirmed diagnosis of peanut allergy based on serum IgE within the past 12 months, or skin prick test to peanut, or clinical history of systemic reaction to peanut within the last 2 years with evidence of sensitization to peanut, or documented reaction to peanut upon supervised oral food challenge as a dose of less than or equal 100 milligram peanut protein. The Palforzia to be prescribed by or in consultation with an allergy and immunology specialist. Also requiring patient not receiving systemic corticosteroid therapy for the treatment of asthma in any of the following situations. Having daily systemic corticosteroid for more than 1 month during the past year, or having more than 2 bursts systemic corticosteroid course in the past year with more than or equal 1 week in duration, or burst systemic corticosteroid course within 3 months prior to starting Palforzia. Patient not having hospitalized for asthma within 1 year prior to starting Palforzia. Not having emergency department visit for asthma exacerbation within 6 months prior to starting Palforzia. Not have history of eosinophilic eosinophilic esophagitis or other eosinophilic gastrointestinal disease. Not have uncontrolled atopic dermatitis. Not have medical conditions that inhibit their ability to survive anaphylaxis, such as reduced lung function, severe mast cell disorder, or cardiovascular disease. Not taking medication that can alter the effect of epinephrine currently. Not experience severe anaphylaxis resulting in hypotensive shock. Use more than 2 doses of epinephrine in or intubation within the previous 60 days. I propose to you the Utah Medicaid prior authorization criteria for Palforzia to have the dose escalation starting between the age of 4 to 17. If the patient turned 18 while on Palforzia, we can consider continued treatment. To be prescribed by or in consultation with an allergy and immunology specialist. Have a documented clinical history of allergy to peanut or peanut-containing food. Confirmed diagnosis of peanut allergy based on serum IgE within the past 12 months, or skin prick test to peanut, or clinical history of systemic reaction to peanut within the last 2 years with evidence of sensitization to peanut, or documented reaction to peanut upon supervised oral food challenge at dose less than or equal 100 milligram of peanut protein. Members do not have uncontrolled asthma or have been on long-term systemic corticosteroid therapy for the treatment of asthma. Eosinophilic esophagitis or other eosinophilic gastrointestinal disease cannot have either, and require an attestation from provider to have healthcare setting prescriber, dispensing pharmacy, and member as certified in Palforzia REM program. An attestation that prescriber have counseled the patient to maintain a strict peanut-free diet while taking Palforzia, and was counseled that they have injectable epinephrine instructed and trained patient on appropriate use and to seek medical attention upon its use if needed. And that concludes my presentation. Thank you.
Great, thanks. All right, any questions at this point?
Let's see. New, can you actually present that, this the prior authorization criteria so they could see that one more time?
Yeah.
Yeah, thank you. Perfect. And so now we do also have Dr. Payne available from Immune. So would we like to go to her before we start discussing the prior authorization criteria? Okay, let's go that route.
Sure, that sounds good.
Good morning, everyone. Can you hear me?
Yes.
Yes.
Excellent. Thank you for your time this morning. My name is Shannon Payne, and I work in medical affairs at Immune. And so I'm going to provide a statement with some information about Palforzia that should help you make an assessment around appropriate coverage criteria for your Medicaid program. Palforzia, as you've heard, is an oral immunotherapy indicated for the mitigation of allergic reactions, including anaphylaxis that may occur with accidental exposure to peanut. It is the first FDA-approved therapy for the treatment of peanut allergy. Initiation of Palforzia, as Noon shared with you, is approved in patients aged 4 to 17 with a confirmed diagnosis of peanut allergy and may be continued in patients 18 years of age or older. It is to be used in conjunction with a peanut avoidant diet. The Palisade study was our phase 3 efficacy and safety study. Its primary endpoint was the percentage of patients that could tolerate at least 600 milligrams peanut protein with no more than mild symptoms at an exit food challenge. At baseline, the median tolerated dose of peanut protein for these children was 10 milligrams. After approximately 12 months of treatment, which included the initial dose escalation, the updosing, and 6 months of maintenance at 300 milligrams per day, 67% of subjects in the intent to treat analysis of the Palforzia arm tolerated 600 milligrams of peanut protein in the exit food challenge with no more than mild allergic symptoms. That compared to 4% in the placebo arm. Additionally, 50% of subjects in the Palforzia arm tolerated 1,000 milligrams of peanut protein as compared to 2% in the placebo arm. After 2 total years of Palforzia therapy, 80% of patients assessed tolerated 2,000 milligrams of peanut protein. And just for a little perspective on that, 600 milligrams of peanut protein is equivalent to about 2 whole peanut kernels, and 2,000 milligrams is equivalent to 6 to 8 peanut kernels. Palforzia contains peanut allergenic proteins, so it can cause anaphylaxis, as Noon discussed. Because of this, it carries a box warning regarding anaphylaxis. And physicians prescribing Palforzia must also prescribe injectable epinephrine and instruct and train patients on its appropriate use. And of course, Palforzia is available only through a restricted program under a risk evaluation and mitigation strategy. The most common adverse reactions reported in subjects treated with Palforzia were abdominal pain, vomiting, nausea, and oral pruritus. And these tended to be higher during the updosing phase, and their frequency declined during the maintenance phase. Adverse events continued to decrease over long-term treatment with Palforzia, so 18 months to 2 years that have been evaluated so far. So again, thank you for your time today and for the opportunity to discuss Palforzia, and I'm happy to answer any questions you might.
Thank you, Dr. Payne.
Thank you.
Questions?
This is Michelle Hoffman. My background is working in hospital medicine, not in the ambulatory setting, and I can envision some circumstances where a family may have difficulty complying with all of the precautions necessary to do this safely in an ambulatory setting. And I'm just curious if you have any perspective on that, if there are alternatives to the ambulatory setting, or if through the REMS program there are certain factors, in particular social factors, that often contribute to these issues that restrict its application in the ambulatory setting.
Yeah, so that's a great question, and it really gets to patient selection. So this is a great treatment, but it's not for every patient. And so that's something that the family and their healthcare provider will have a conversation about. These are the things that you're going to need to commit to in order to do this safely and effectively, because if you can't do it safely, you can't do it effectively either. So I think that's really a conversation for the healthcare provider and their patients. Does that answer your question?
Yes, thank you.
Uh-huh.
I have
Do you
a
think-
question. Sorry.
Go ahead.
Oh, sorry. So if each dosing of updosing is every 14 days and the pharmacy won't dispense before that, what if patient happen to have lost or missed the medication?
So if I understand the updosing, I think there might be an extra dose in the updosing kit in that event, but also the healthcare provider has what's called an office dose kit, and that's for use in, so when the patient comes in for their first day of updosing, that office dose kit is used to dose the patient on that day. And so that can also be used in the event of, like, if there's a one-off missed dose here or there.
And if the patient cannot reach the 300 after the updosing, like they stay at 100 milligram, will that going to be their maintenance dose if they cannot reach the 300? How many attempts would you trial after that?
So the only maintenance dose is 300 milligrams, but the really good news is that you can take as long as you want to get there. So you can't go faster than updosing every 2 weeks, but if the healthcare provider feels like the patient's not ready and wants to keep them at their current dose level, whatever it is, 60 milligrams, 120 milligrams, they can keep them there for 4 weeks or 6 weeks or whatever they feel is the safe and effective thing to do.
Thank you.
Back to Dr. Hoffman's point, I'm just interested, our experience with REMS, at least mine has been mostly in the use of controlled substances. And so the patient registration part of that, I think does get to some patient selection. And I see, this is on a REMS as well. So while we don't have, any of the social determinants necessarily kind of built into the PA criteria, and I think that begs a huge discussion. There is something in the REMS process that kind of gets you to that. There's, just as a process, it's another level of complexity that, at least in my experience, I wouldn't be doing this per se. This is not my, the pediatric patients that I see. I'm not doing allergy and immunology, but I have done REMS with pediatric patients and controlled substances. It definitely gets you to a narrower population. So that was just a thought there. There's another layer there of, I guess, commitment or ability to kind of handle the complexity of it. Just a comment, I guess.
Thanks, Sharon.
I have a question around real world utility.
Mhm.
Um, Ultimately, if a person reaches 2,000 milligrams, I believe is what you said, it equates to about 2 peanut kernels, tolerating to
6 to 8.
6 to 8. Okay. So real world, is this medicine meant to help with avoidance of any sort of trace exposure or accidental exposure that may occur?
So that's the entire concept behind Palforzia. It's to mitigate these accidental exposures that lead to children ending up in the ER. And actually, there was a lovely study done by a group in Belgium a couple years ago in which they managed to intercept patients that came to the ER with peanut-induced anaphylaxis and were able to quickly find that bite of cookie or the piece of cake or whatever it was that they had, and were able to back calculate what they believed the accidental exposure was. So the median accidental exposure in these patients that had these significant reactions to peanut due to accidental exposure was 125 milligrams. So even the 600 milligram primary endpoint in the Palisade trial should be a good buffer over that median accidental exposure, but certainly we would hope, 6 to 8 peanut kernels or 2,000 milligrams should be a buffer to mitigate that accidental exposure. We're not saying the patient can go eat a peanut butter and jelly sandwich. The goal is to avoid accidental exposure.
Yeah, thank you. And thank you for sharing that other study as well.
Mm-hmm.
I have another question for you. Do you know how many patients in the trials didn't make it past the 3 milligram point?
Oh, that's a great question. I can see if I can find that information for you. For the Palisade trial, I can tell you how many patients didn't make it all the way through maintenance, but 3 milligrams, I don't know. I don't think there were very many people who dropped out on the initial dose escalation day. I think there may have been a handful. The patients that didn't make it all the way through the maintenance, it was about 20% for the Palforzia arm and about 10% for the placebo arm. Though, yeah, there are a lot of logistics involved with that as well. But
Great, thanks. All right. So are we ready to move to committee action on this?
Yes, I think we should start talking about the PA criteria that has been proposed, and then we could go from there.
Sounds good. Any edits that we want to recommend here?
I'm curious about whether this should be limited to allergy and immunology specialists versus others just acting in consultation with.
That was the same question I had. I mean, I don't know that this is your typical family practice drug.
I think that's reasonable as well.
Does bullet point 2 already cover that though? So are you?
Yeah, the bullet point, because it is in consultation with a specialist or prescribed by a specialist. I think you're right. I think bullet point 2 covers that pretty well.
I'm wondering about that it opens the door to just doing consultation and having it be managed and prescribed by, I don't know.
So
This goes back to the REMS for me. I'm sorry. If a general pediatrician were to start out on this, they would go through the REMS training as well, and so they would have there's another layer. Now I know that could be sometimes what looks like checkbox, but usually there's education in there, and then we would be saying here in the PA. They would be doing this in consultation. I don't imagine that. I don't imagine that this is going to, have a wild uptake in the community. So I think for the occasional pediatrician who might be willing to go through all the steps, I'd be guessing they'd be committed.
And to piggyback off of that,
I'd be inclined to leave the bullet as it is rather than restrict this to specialists given the access issues, but I could go either way.
mm-hmm. And
I'm just thinking
I
oral.
agree with Dr. Weinstein in terms of access, since we are considered a frontier state, and you have to have 2 days in a row in the office and then every 2 weeks for an extended period of time in the office. And you think about somebody down in the Blanding area or, St. George, and if there's not an allergy specialist available, every 2 weeks to come up to Salt Lake is not really practical for families.
Agreed.
That's my thoughts.
But yeah, agreed. Still worry about safety of this kind of care in a rural setting, but I understand the access issues.
Still, does that need to change bullet point 2? Because even when you're remote, you can access support from an immunologist.
Yeah.
This is Joe. I'm just taking notes. Did I hear that a question about defining what that consultation looks like? Is it a phone consult? Does the patient actually have to be seen by the specialist? Did I hear needed clarification around that? Or are you comfortable with just that language?
Joe, could we put maybe prescribed by or in documented consultation with an allergy or immunology
Sounds good.
specialist? Just so, someone just doesn't pick up the phone. They had a consultation, things moved on, just was busy, but I don't know. Just having that word in there makes a difference, because that could speak to how the conversation and consultation took place.
Thank you.
I like that. Thank you for that suggestion.
Thank you.
So that means we want the primary clinician to consult with the specialist, not necessarily sending the child. When we say prescribed by or with documentation of consultation with, we're looking to see that the prescriber consulted with the specialist, not necessarily that the child has to go running all over.
That was my thoughts initially here.
Okay, I'm just, yeah, just what our intent is, as opposed to that there has to be, that there would have to be additional visits. I mean, because there's also remote care, right? Which we're finding is improving access. So do you want to say documented or documentation of? I think that might not be spelled correctly. Sorry,
yeah, documented.
Yeah.
And I would say, just for ease of reading, or in documented consultation with.
I'm still thinking about the comment you made, Dr. Hoffman, about the family having kind of the necessary support to get through the full treatment and whether maybe that should be on there.
I mean, I feel fairly comfortable with the prescriber based on the discussion around the REMS program and what participation in that program takes, that they're going to take all of that into consideration. Obviously, I don't think they would jeopardize of somebody who felt like they, wouldn't be able to be successful with this.
Okay.
So I'm comfortable not, just based on the conversation and comments from Sharon.
Okay.
Earlier.
Also, are there tools that the manufacturer supplies to the patient once they've enrolled in the REMS, and other tools to help with ongoing education and support with the product?
In other REMS program, the pharmacist is an essential, part of the team as well. I would imagine with this, the dispensing pharmacy is in there too with the usually, in the REMS, there are patient education tools that not only the prescriber, but the pharmacy has at hand. And every time the products are dispensed, the pharmacist has a role as well. I would have, I would have pharmacy speak to that, but that's part of the REMS program, is to, in terms of risk mitigation, to have all of these loops of reinforcing education built in. So I would, I haven't looked at all of the materials in this REMS program, but that's essentially the scaffolding of the REMS programs, or all of those repetitive education loops at each point of care with pharmacy and with the prescribing.
Yeah,
So
I just haven't seen how these are dispensed. I was looking at the medication for use guide and how they're dispensed, just to see if there was just ongoing support. I don't. Shannon, can you speak to that in the packaging or things like that, just that help reinforce these things?
Sure. Yeah. So the company does provide patient and caregiver support through a treatment guide as well as a website.
Okay. Thank you.
I have a couple of other comments. So eosinophilic esophagitis and gastrointestinal disease are pathologic diagnoses that require biopsy. And so I'm curious if we should include gastroesophageal reflux disease, which is more of a clinical diagnosis, such that if that's present, would you need to exclude eosinophilic esophagitis, I guess, is one of my questions. Maybe that's for Shannon.
So I apologize. So you're asking, should eosinophilic GI disease be excluded?
No. Since that is an exclusion, but it requires biopsy to confirm that diagnosis. How would we respond to a child that has gastroesophageal reflux disease, but has not proceeded with endoscopy or a biopsy to confirm whether there is a component of eosinophilic esophagitis?
I think that's going to be something that's going to be left to the prescriber's discretion. Certainly, if you have significant concern that this is an eosinophilic GI disease, then Palforzia is not the treatment to put the patient on. I don't know, because an endoscopy is a somewhat invasive procedure, to check for that. I'm loath to say that should be something that is required to be done on these patients, but certainly I would hope that the provider would take into consideration that you don't want to undertake Palforzia treatment in a patient who has eosinophilic esophagitis.
I wonder if we just add pathologic diagnosis or clinical concern for eosinophilic esophagitis. That way they're at least thinking about it as they're doing their history.
So Dr. Hoffman, you're concerned that this is the way this is worded is not getting the clinicians into the territory that they need to be here.
I'm a little bit concerned, yeah.
Mm-hmm.
I just want to prompt people thinking about it based on their review of systems as they're assessing an individual for this.
Right. So if I understand correctly, so a certain subpopulation of children with GERD, with gastroesophageal reflux disease, would need to be further evaluated with endoscopy and biopsy. So we want to have some language here.
What about if we had
reference that?
What if we had does not have diagnosis of or symptoms concerning for eosinophilic esophagitis or other eosinophilic gastrointestinal disease?
I like it.
Yeah, so it gets them moving into that, like they've thought about it, or they, you know, it's obviously if it's diagnosed, yes, but you want the other kind of you've thought about it, or there's something concerning for it, then you're in the territory to work it up. Yeah.
Yep.
Dr. Gagaro, would you mind repeat the language?
Yeah. Diagnosis of or symptoms concerning for.
And then my final comment is around the epinephrine. You know, based on our discussion around access issues, certainly access is more than access to physical care locations. There's also access to the medications required to administer this safely. What sort of checks and balances are there to ensure that there aren't access issues to obtaining the epinephrine in the REMS program?
From Utah Medicaid standpoint, we do provide coverage of epinephrine. It's on the PDL. We have preferred epinephrine products, but we haven't, you know, if someone's not able to get one, we've been good about letting people get a different one if they're not able to get a preferred one.
And as a parent of a child with a food allergy, my experience was that the epinephrine was through a specialty pharmacy that they mailed it to our house.
Okay.
Should we include something like that?
Yeah, I was going to suggest that.
Verify that they have an injectable. It even speaks to that in the insert.
Yeah.
Right. So not just prescribe, but
verify.
Patient must have injectable epinephrine and be instructed and trained on its appropriate use.
Yeah.
The way we do it is usually like our team, I mean, they can check the box, but we could look for a paid claim for it.
Right.
To make sure it's not like an expired or old one.
Right.
Yeah, I think just some checks and balances internally to make sure there aren't access concerns there would be beneficial.
Yeah.
On our naloxone kits, we have, you know, patient has active unexpired kit at home. It's not the one we wrote in 2015.
I think that's a really good point, because I know that I have at times I have a daughter with a peanut allergy, and at times I have seen that our EpiPen is outdated.
Yep.
I like that language of active, unexpired, injectable epinephrine.
In their possession, right?
Yes.
Yep.
Sorry, just taking notes.
Well, are we ready to approve this?
I wanted to, the committee wanted to add reauthorization criteria, and at what point
Mm-hmm.
in the process. Because this does require a significant amount of compliance on the part of the member and the member's family.
I like that because, you know, if you have a family that's had to restart the escalation multiple times, that's a really good indication that they're not able to comply with what's necessary for the treatment. So I think having a criteria about, number of dose escalations that would disqualify in a period of time. Maybe unless there's been documentation of changes that would support future compliance.
Is there any, are there any data to, excuse me, experience in the field to date to go by with this? I mean, do we know what's a reasonable expectation with utilization of a product like this to know, what kind of variability we might expect, and then at what point would we say, this is a non-therapeutic use and cut it off, or what's the clinical judgment of our pediatric colleagues here?
I'm not sure you need to have a non, I mean, if you have a peanut allergy, this is a very helpful thing to get because you can get exposed to peanuts in so many different ways, intentionally and unintentionally. So I don't think there would be a reason to, there'd be a diagnosis of a kid with a peanut allergy where you would not want this, except for the ones we've already excluded.
I think, Jen, the question is targeting if they're unable to consistently follow through with the treatment course in terms of the dose escalation within the time frame required without needing to repeat and start over. Is there a point where we would suggest that this isn't the right therapy for that person and family because of compliance issues?
I see what you mean. The thing about immunotherapy, is that there are a lot of things that make kids start and stop. And so I'm not sure I would put in a barrier right now because each time you resume, it doesn't increase your risk because you're going back, there's a plan for going back to the lower dose. And family situations change. I say this as a parent who has a kid who goes in for allergy shots all the time. And there are things that come up where we get behind or, we can't get in. Anyway, I don't think that having an extra barrier is needed. It doesn't promote safety because, again, if you miss a shot, if you miss a dose, then you go back down if it's been long enough. So there's already a built-in way to keep kids safe. So I don't think that that's needed. And at least during the time they're getting the therapy, they're probably protected a little more during that time. So even though it's a start and stop, you're still getting some support there. There's that phrase, 1,000 false starts means you did it 1,000 times. But
yeah, I guess my concern with that is, what are the safeguards in place to make sure that a family who has difficulty with compliance is actually following kind of those guidelines in terms of missed doses? And is that creating a safety issue? I mean, I guess that probably would go with dispensing and be on the prescriber's end. But just something from that standpoint.
The REMS will eventually expire and have to be renewed. The REMS is not indefinite, so I mean that's an end point eventually.
Thanks. I haven't had a ton of experience with REMS.
I also think too, from our perspective, when we review prior authorization requests and look at compliance, which is something I think the pharmacists are doing, they're going to look at the history of use and look at the dosing history when they're evaluating the request. There is an opportunity for, like, we call it peer-to-peer outreach with the provider to discuss any barriers, because we're not going to know when we evaluate, hey, this child was shifted from foster home to foster home, or, this or this or that happened. And we always need to keep that in mind and understand their circumstances that we aren't even going to be aware of. So I think it is an opportunity for us to do, if there is a concern around safety, and the dosing regimen being stopped, started, backed up, things like that. That is a place where our pharmacists should be reaching out to providers and talking to them about why that may be happening and being in agreement with them on why this path forward is selected for this patient at that time. And you can address safety concerns in that conversation as well if needed.
So with the prior authorization forms and the criteria, would it be that this has to be renewed yearly on there? Is that kind of standard language? Because right now with this criteria, we don't have any time frame in terms of the duration of the initial authorization and any renewal.
We generally use, I'm sorry, Brian. We generally use soft language, so we could say up to 6 months or up to 1 year for renewals. And so it allows us to have and determine appropriateness maybe for that specific case. And we've kind of adopted this up to language. I think, Brian, is probably what you were going to say, to allow a greater flexibility for certain circumstances. If someone appears stable and they've been steady Eddie all along the course, I think the pharmacists are more likely to approve a longer course of approval, like up to a year, right? And then in circumstances where we don't see that, that's where we would probably shorten the approval timeframe to get establish some of those things.
So do we want to have that the initial authorization is up to 6 months and then up to 12 months thereafter?
That seems reasonable.
Yeah,
also, typically what we have for reauthorization, and obviously it's going to vary from drug to drug, but a typical reauthorization criteria would be a positive clinical response. In this case, we're not wanting to see a response. We're wanting to see that they're tolerating the therapy. And I would think that would be sufficient if the patient's tolerating the therapy and the prescriber attests to that, that would probably be sufficient for a reauthorization.
Dr. Brinton had some connectivity issues, and she asked me to ask if the manufacturer has any data on in-home compliance.
So I'm trying to understand the question. So how is the question how often patients take their medication daily as they're supposed to, or?
So I lost my connectivity when we were talking about this. So you guys might have already addressed this. But the question that came up from the team was the safety of families, not necessarily being compliant in the home setting, and whether we needed to have some type of way to enforce their safety or to, do things to help keep patients safe. So my question had just been, what has the data been? We do have these doses given at home. When the kids come in for the allergy appointment afterwards to get their next dose, that would be pretty apparent if they've not had their, maintenance doses. Just if there's data on that we need to be concerned about, or if there's not been any adverse issues that, just the question is how much of a concern is that for the in-home setting where patients might not be compliant, but they might not let us know either.
Right. So in the course of the trial, it's really hard to, when patients aren't telling you, it's hard to know, because sometimes, you could skip a couple of days and you might react or you might not react. And then if they do react, you don't know, did they skip their medication, or are they just having some kind of reaction to their usual dose? So I think the important thing is that patients and providers and families have really, really open lines of communication. And it's okay if you missed your medication this day, tell us, and that way we can figure out what, how to move forward. If you missed one dose, okay, then you can take the next dose at home as planned. If you miss 3 or 4 doses, then come back into the physician's office to dose again, so that we can make sure that you don't have any adverse reactions. So it's really about having an open line of communication, and everybody being on board with that, which I think is part of the patient selection and the REMS process. Does that answer your question?
Thank you.
And we think 6 months initially will give most people adequate time to accomplish treatment.
I mean, they may not be up to the full maintenance dose if they take a long time to wind up, but at least that would be a time frame that you could have some documentation of tolerance and, that they're utilizing the medication in conjunction with the physician.
Right. I mean, I'm just thinking then the, staff will be looking at this, and some proportion of families will still be working up to, to the desired endpoint.
I wouldn't say necessarily that it would be an issue of dose as much as, are they complying with the updosing phase, or are they having to, and the interval is not so much a problem as, are they coming in for their appointments every 2 weeks at that point, at least, or every 6 weeks, however long the interval is between the updosing. Are they complying with that part, hopefully at that part of the dosing phase?
And these will be required to be face visits, do we think, or could these be video visits?
My understanding of the updosing phase is the first dose has to be taken in the healthcare setting, and
for anaphylaxis,
right.
I get that. That's not something we can treat remotely, but in subsequent visits, I'm just thinking about the logistics and what's going to be happening over the next 6 to 12 months with accessibility and safety.
The requirement includes that the first dose at each updose phase level, I believe, has to be.
That's an in-office visit. Right.
Right. And that's what I'm speaking to, is that are they coming when whatever the interval is?
Right. Right. So we may see some fits and starts with this, just in terms of what we're dealing with the pandemic too. So, you know, I'm just thinking, you know, staff may see a lot of protracted, you know, I don't know how much of this is, how many patients we're actually going to see. It may be a small number. It may not be a huge workload. But I was just thinking about, you know, is 6 months short to have you reviewing it initially, but it doesn't bother me. It's erring on the side of caution. That's all. Thank you. I'd move to that we approve the proposed criteria as written.
Thanks.
I'll second that.
Great, we have a second. All right, so if we're taking a vote here, all those in favor say aye.
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 Any opposed? Abstentions? All right, thanks. We have approved criteria now. All right, are we done with our agenda? It appears we are. All right, anything else we need to talk about before we adjourn?
No, nothing comes to mind.
Okay.
Yeah. Thank you again for everyone. I really appreciate you guys attending.
Thank you.
Thank you.
Thank you.
Stay safe.
Have a great day, everyone.
Yep.
Good to see you
ya.
guys.
Thanks, everyone.
There.